Presenting the next case from Madras Medical Mission.
18-year-old male with tetralogy absent pulmonary valve syndrome was operated when he was 11 years old with a intracardiac repair, VSD patch with RV to PA 23 millimeter pulmonary homograft. The proximal part of the pulmonary homograft ballooned out, whereas the distal anastomosis of the pulmonary homograft to the dilated pulmonary arteries developed severe stenosis. This distal stenosis resulted in more and more proximal dilatation, and the proximal pulmonary homograft's valve totally started leaking. For this distal conduit stenosis, we initially did a balloon dilatation. This balloon dilatation was performed about 6 years after the surgery with a 25 millimeter Z-Med balloon. There was a very short-lived reduction in the gradients. Next, so within a short time there was a recurrence of stenosis, so we did a conduit stenting with a 29 millimeter Zephyr XL stent on the same 25 millimeter Z-Med balloon. The RVSP came to 40 at the end of the procedure, and the gradient was 18 at the end of the procedure. There is free conduit regurgitation. Next picture. Next. Okay, run this. So this is the final post-conduit stenting angiography, where we have an angiographic dimension of around 23 millimeter. Show the CT. The CT scan shows that the waist of the stent is around 22 millimeters. The stent is in the distal part of the confluence, almost at the pre-bifurcation. Aneurysmally dilated right and left pulmonary artery. The proximal MPI is actually the pulmonary homograft conduit, which has become very roomy and dilated, and the valve is leaking. And so this is the landing zone for the stent. And now, actually, when I was in the other lab, my colleague Dr. Pramod was working here, and he did the basal hemodynamics. Pramod, what was the 50? RV was 58 and distal PA was 28. So there was a 30 gradient across the pulmonary homograft. So now what I have done is, we have crossed that stent on a lateral projection. I have now inflated a 12 millimeter Mustang balloon. This is just to confirm that I am not passing through any of the side struts. So after this, the next step will be, I'm going to dilate it to a much larger balloon.
Can we see live fluoro, please?
Yeah, live fluoro B. So what I did was just advanced a 12 millimeter Mustang balloon in order to just ensure that I am not passing through any struts of this valve. And at this point, I am taking the 26x4 Atlas Gold. I am going to fully open it out. This is the distal anastomosis.
Shiva, my question to you is, are you worried about stent shortening in this case? And my corollary to that was that why did you use a 29 millimeter stent and why not a 34?
Actually, if you look at that, can you show that PowerPoint last CT scan once again? PowerPoint last CT scan. You see, okay, CT scan bigger. Okay, you see that here, the actual narrowing was very short, Bharat.
No, I agree. Your placement is absolutely perfect. My concern is about stent shortening when you go with higher diameters.
This is the Zephyr XL, which does not foreshorten at all. We have written the paper on this Zephyr balloon. It has got the C and S links, which prevent any sort of shortening. It doesn't foreshorten at all.
Okay. So what was the length of this stent that you put in?
The
29 millimeter.
29 millimeter.
29. So what is the length on the CT now?
It was more or less the same, 26 or something, 26 to 27.
So it didn't foreshorten.
Actually, in different planes it had different dimensions. Shaq, you can now appreciate in the inferiorly it is a little shorter, superiorly it is a bit larger. That is the nature of many of these stents, including CP. They eccentrically they dilate. They eccentrically they dilate. Yeah. So now what I am doing is I am going to dilate this to 26. Fluorostore, run it again. Run it again.
You should have fluoroed when you were deflating as well, but never mind.
You wanted it in the previous case as well, Shaq. Sorry, I forgot.
Yeah, no, it was just to see recoil, if any. I don't think there is, but
I
so
will do it
what's
once
the
again.
length- What's
will
the
do it.
length of that stent?
I will measure it now. I will measure it. I'm going to again dilate because Dr. Vishnu felt that he couldn't pull the balloon sufficiently. Okay, now keep it there. Tell me the number. Measure the not much of recoil, Shaq. I will
No,
measure
that's
it.
good. Just measure the length.
Yeah. Measure the length as well as measure the diameter. Use the calibration.
So is your plan to use this as a distal anchor for a more proximal stent, or you're going to put a valve in this area?
Valve in this area. I'm planning to put a valve in this area.
So then the length of the stent is an important factor to some degree, unless you're going to, I guess you're going to use a sapien, obviously, at that
No,
size.
Can we inject now?
and it's,
Inject
Myval,
now.
that's-
I think
30
Myval's
ml, 18
shorter than
rate.
sapien,
Ready?
I think.
What size?
Ready?
They go up to 32, but the length, I think, is shorter than sapien, but we'll check.
Okay. Now in this you can measure. You can make the measurements based on the catheter or something. I think the approximation is quite appropriate. I will make a coronary angiogram now.
Any questions? Again, this is a fascinating case that she was doing, very challenging stuff.
Shiva,
Yes.
are you worried of the proximal RBOT stenosis? I think the dynamic obstructions.
Of the
Dr.
proximal
Shiva.
RVOT in that right ventricular conduit junction.
Yes, I think that the proximal part, proximal RBOT.
Top up fully. Okay, I want a guide catheter to record the pressures. Or another option is give me the right coronary artery catheter. Come back to AP view. I want to put the this one deeper. Is somebody measuring the stent?
Sonia's got a question whilst you're measuring.
RC.
Dr. Shiva,
Yeah.
when you were choosing this stent, you did not expect any calcification in this case, so you choose an uncovered stent, and if you had calcification, which stent would you have used?
Covered stent. Covered stent, we have options of covered Zephyr, covered CP, so one of the covered stents. This is not much of calcification. So in non-calcified conduits or very minimally calcified conduits, we go for bare stents. So we have around 25 millimeter length also. I want length.
Yeah, I wanted length as well.
Yeah, correct. Go further.
Without the contrast.
Okay, okay, without the contrast.
Without the contrast.
Save it, go back. Empty the contrast. Correct, freeze it.
That's the one.
Now you just measure now you measure only the diameter and the length. Just take it, correct. Go for little beyond. Okay, not so much.
Not that much.
Not that much. Who is measuring?
It's not calibrated, it's giving you pixels.
Okay, that's enough. Now take a vertical dimension.
No, that's giving you pixels.
Yeah. No, but it's just for comparison, Shaq, because the other one was 25. Okay, more
I
or less
see.
matching, sir, Shaq. It's maybe 25 by 25.
Okay, so 29 has gone down to 25, yeah?
Yeah, correct. But Shaq, I will tell you.
No shortening.
This is because This is because the distal part, the proximal part were all roomy, and so when we put in a larger and larger balloon, it
Yeah, it
actually
shortens.
it dog bones. In fact, if you like during my previous procedure, I had used a coda balloon to flare out the edges. So basically, in true blood vessels such as coarctation and all, there will not be. Actually, this is 28 is overestimated. I would say it is 25 or 26 should be the correct size.
Yeah. Whether it dog bones or not, it shortens. Yeah, that's simply. Okay,
agree.
so carry on with the next bit. I don't want to delay you too much.
Yeah. Show the wire position.
Shiva, there is a VT.
No, it's my catheter is going touching
Causing the VT, yes.
Okay. You see that the valve is not circular. Can you come to like RAO, little RAO, little LAO, LAO further, enough. A little caudal, a little cranial. Okay, that's no. Let reduce. Okay. Yeah, it's not bad. It's not too eccentric. Okay.
And have you done coronary angios? Because you might as well do it on this view.
Okay, I'll do that now. Be there.
There you go.
Looks good.
So now I am changing it into the Python sheet. Python sheet ready? Okay.
So Kevin, the stent there, good position, 25, 26 millimeters. Next in your lab,
Probably a 29 sapien, I think. It looks like it would take it and flare, and there's probably enough tissue, to get a seal, particularly, because you're
26 ml, 26 millimeter with 3 ml extra.
so
Yeah, I mean that's a good option as well. I think 29 might be a bit easier, and they're huge pulmonary arteries.
Yeah.
okay.
Yeah, get the
Any other differences of opinion?
Okay. See, what I'm going to do is something.
Thomas?
I just joined 10 seconds ago, so no, I don't have a different opinion.
Yeah,
Okay.
bring
So
the
26 sapien, 29 sapien.
29.
Thanks.
Yeah, Basil.
You know, the problem with my valve and Edwards valves are this valve to achieve the best hydrodynamic result, okay, should achieve the diameter of production. Let's say if you put in this patient and 29 valve, and valve goes up to 26 or 26.5, is not going to work well. You may have stenosis or
This is
regurgitation.
26 plus 3?
That has been reported.
Okay. So you would rather put 26 with extra volume?
My valve, I think, is also...
Use the microphone, because,
My valve, I think, is also available on 26.5.
yeah, okay.
Okay. So Shaq, what we are doing is the valve that Dr. Basil was talking about. So this is the Myval. This is an Indian valve. It's something similar to a sapien, but it's a volume-dependent inflation that if you give additional volume, it inflates more and more. So what we have done is we have taken a 26 millimeter, and you are holding the wire here. So 26 millimeter, and I am inflating it to 3 ml extra. So can we go to the lateral view?
So Shiva, whilst you're doing that, is there any difference in the height, valve size for size between sapien and Myval?
Myval is available in intermediate sizes.
So length,
Length is more or less sort of similar.
how much?
It's more or less similar.
Oh, similar.
It's we don't have it's pre-mounted valve. We don't mount it in the inferior vena cava and push it up.
Okay.
So right now I have got the this is a 26 millimeter Myval, which is going to plus 3 ml, and so it will go to 27 or 27.5. So now as he is inflating, I'm going to adjust the position.
And what French introducer did you have
It
to
is
use?
similar to E sheath. This is called Python sheath. Can you keep inflating? Then I will adjust.
Titan.
Python, snake,
No, snake.
snake.
Not the Titan submarine.
Python,
that
Python. Yeah, keep inflating.
crashed.
Keep inflating, keep inflating. Inflate, 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 full, full, go complete, empty, 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 rotate, 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 full, deflate.
He's squeezing.
Yep.
Okay, well done.
So that
Yeah,
is the,
Basil?
Yeah, the Myval has
Fully
the
deflate.
advantage of different sizes and also has a very, nice delivery system, so you can push it and the valve goes easily
marker
down.
pigtail.
Yeah.
Show the fluoro. Show fluoro.
And it goes up to 32, doesn't it, currently, I think?
Yeah. I think 31.5 is the last, but you can
In
get
fact, it
another
goes
50
to, there is a valve that is coming up which will go to 34 to 35 millimeter. That's called as the double extra large Myval, which will be meant primarily for this hugely large native RVOTs. Right now we have experience with the 32 millimeter on many cases. We probably will be launching a study on this extra large. Even the what is more than 29 is called as extra large because Sapien stops at 29. I am now advancing my pigtail, marker pigtail, into the outflow tract.
Watch your wire. Oh.
Okay, now I don't need this coronary catheter anymore. I'll just make one coronary injection and pull it out. So now I will disconnect the aortic pressure. This is distal pulmonary artery pressure. Second pressure line. This is right ventricular pressure. Give the hemodynamics large. There is a good hold up of the pulmonary artery pressures. This is the right ventricle large. There is not much of gradient. It's looking good. There is, you are able to see the pressures, Shaq?
Yeah,
very
we
well.
can, yeah.
So now I'm going to make an angiogram of the pulmonary valve.
Virtually no gradient, so that's good.
Show the, this one big, fluoro big. Okay. Ready for angiogram? Shoot. Okay, there is no regurgitation. The dye is stopping there. I will make one RV angiogram now. Put in a like thermo wire first. You will get a figure of 8 now. Or arrange a figure of 8. Now itself get it organized. Ready for the angiogram?
Yeah, brilliant. Very
looks
good
good.
indeed.
Nice result.
So what we'll do now is, Shaq, there is a very interesting covered stent exclusion of sinus venosus defect in the other lab, and I am marching there. I would like the presenter to give the PowerPoint presentation.
Shiva,
Yep, I'm hearing you, Shaq.
tell your team in the cath lab they've done a brilliant job,
Yeah,
including the one who was doing the indeflation. Big hand for them.